Are you facing challenges in your health? Then Dr. Suleiman Clinic and Labs is here to provide you with the lasting solutions to your health problems. Dr. Suleiman Clinic and Labs is specialized and offers consulting in psychiatry, internal medicine, cardiology, urology, dermatology, gynecology, infectious diseases, and infertility. At Dr. Suleiman Clinic and Labs, we offer 3D/4D scan at just 5,000 francs, emergency ambulance, free ultrasound scan, and free medical consultations. Our staff is composed of well-trained doctors with good laboratory and best equipment. We are located in 2 cities, Boya at Mile 18 Bolifamba, and in Douala, we are located at Entrée Pilote. You can reach us through the telephone number 694-940-172. Your health is at the right place with Dr. Suleiman.
I want to share with you now the next step that we have done for this patient, which is the echocardio. Why we're doing the echocardio in this case? To decide, again, why we have left axis deviation. Is it too much blood, volume overload, or the walls of the heart is very thick? This is why we're doing the echocardio, to decide which category you belong to. And I repeat again, the treatment is totally different. The treatment is totally different. Let's check the second video, please, and then we talk about it.
On this patient heart, and if we look closely at the results, it's an auto-translation, meaning the machine will auto-translate, and plus the doctor will have to confirm this finding. Number one, as we can read together, we have sinus bradycardia, and that is not a good thing. Bradycardia meaning the heart rate is slower than 60, so we're beating at slower than 60. That is a problem. Number two, we have left axis deviation, meaning it could be dilation in the heart, or it could be very big, thick-walled heart. One of the two. How we're gonna tell the difference? By doing an echo, and the echo will tell me if it's dilation, extreme dilation of the left ventricle, or it's just actually an extra growth of the muscular layer of that left ventricle. We have also complete left bundle block, which meaning the electricity in the left bundle branch of the heart is not transmitting. We have old MI, so this patient already been exposed to. All right, so now we are doing the echo. The echo basically, I'm looking at the heart with a scanner to look. Number one, based on its.
Okay. So we see the ECG again, and then there is something also when we read the ECG, there is left bundle branch block, meaning what? I wish I had a drawing to explain to you, but anyhow, we know the heart generates its own electricity by a generator called SA. And then this electricity is being regulated, so the voltage doesn't go too much or too low. It's regulated by something called AV node. So now we have generator of the electricity, and then we have regulator of the electricity, and then from this electricity will go wires to the left side of the heart, and then wires to the right side of the heart to give the impulses to both sides of the heart at the same time. What can happen? What can go wrong in this case? We can have an MI, myocardial infarction, meaning a small piece of dead cells, dead spot on the heart. That's what we call a heart attack. Heart attack meaning a small piece, a region of the heart, a spot of the heart has been killed. The cells has been killed, and dead things do not conduct. When we have dead tissue, they do not conduct electricity. So myocardial infarction in simple English means heart attack or dead cells, dead spot. There is a region in the heart that has died off. There is no more conduction through that region because dead cells do not conduct electricity. So when we have an MI, so that young man has already have a heart attack at the left side where those wires are going through the left ventricle. He has already a heart attack there. That means has some cells of the heart has already died off, and that is why when the electricity comes to go through the left side, it cannot go. So if electricity cannot go, and we know when we have the impulses, is because of those impulses that the heart contract, then we can assume if no electricity going through the left side of the heart to make it contract, then this left side of the heart will not contract, or at least will not contract completely, because we can have that when we have the MI, we can have the dead cells compromising some of those wiring going from the AV node going to the left side, or the whole bundle. We call it bundle because it's exactly like electrical wires. Bundle, the common bundle. And this bundle now being distributed all over the left side of the heart, and the other side of the bundle distributed through all the right side of the heart. So if we have a heart attack that target the left side where the bundle is passing, we're gonna have no conduction in that area. We're gonna have no conduction in that area, and that tells me no impulses is going there. And if we understand that impulses is the reason we have the contraction, that means no contraction will take place into the left side of the heart. And that is what the ECG machine showed me. There is no other way to know about conduction unless we do something called ECG. And when you do ECG, I don't want you to do the 6-lead ECG. It is not inclusive. I want you to do the 12-lead ECG that will test all the heart, from the front, from the sides, from the back, from everywhere, from top, from bottom. Is gonna see, the global vision, the global view of the heart can only be conducted if we have a 12-lead machine, an accurate machine. There are machines out there that cannot make a mistake, meaning they auto-translate what the impulses from the heart they see, and they translate it into the different conditions. Like this machine here translated for me that this patient have no conduction to the left bundle of the heart, which means the contraction of that left side of the heart is minimized. So, but if I look at the machine, if I look now, like we have seen in the echocardio, we've seen the whole heart is contracting. How you explain then, if there is no electricity going to the left side of the heart, how is the heart contracting? The heart is still beating because the right side is good. So the heart is a whole unit. The right side contract and it takes the left side with it. It takes the left side with it. So now if we get a second heart attack and the right side is compromised at the passage of the bundle, then this heart is dead because this heart can no longer contract. So the heart contract because there is wires going from that AV node to the left and to the right. And in this patient, we discovered that there is no electricity going to the left side of the heart, yet the left side of the heart is still contracting because the right side of the heart bundle is intact and the left side is contracting, and it takes the right side is contracting and it takes the left side along with it. And that is how come this heart is still beating. Let's go further now. We need to investigate. Like I told you, we need to know, is this left axis deviation? In simple English, that ECG that tells me the heart is enlarged, is it because too much blood inside that cannot be kicked out, cannot be ejected out, or is it because the walls are very thick? Let's watch the next video and let's see what the echo will tell us.
Ventricular parameter as far as to determine exactly how the heart is going. So this is what I'm doing right now. I'm measuring the interventricular septum. And then this is the blood, and the black space represents the blood of the heart. And then we'll go a little bit down. We'll get the posterior wall of the heart. And this measurement will give me the EDV, end diastolic volume, is 96.15. It's not too bad. 96.25. Okay, 96.15, right, EDV, 96.85. Now we're going to bring the heart to the systolic position. Systolic meaning in contraction, okay, which is the smallest possible. This is when the mitral valve is closed. This is the mitral valve is closed, aortic valve start to open, and this is systole. And now we're gonna see now the wall gets thicker. So we're gonna measure here, and then we're gonna measure here, and then we're gonna measure here. And that will give me the rest of the parameters. We have ESV 47. We have ejection fraction of 50%, 0.75. EF, ejection fraction, 50.75. Is not too bad. Is not too bad. Okay, so that means this patient here, we have systolic dysfunction. Systolic dysfunction. We're not missing much, but a little bit of medication will fix this.
Yes, so we have seen. So let me go over what we have seen here. You know, there are three parameters to decide what condition this patient is in. What I have done is maybe a bit complicated for you to understand. We basically measure the function, the parameter of the left ventricle. Okay, we measure the parameters of the left ventricle. How did I measure it? It's a bit complicated for you to understand, but we see the thickness of the wall, and then by a different mechanism, the machine calculates for me. I just know what to measure, and the machine will do the calculation for me. Basically, what I need is how much blood is, at the end diastolic volume, meaning the end of diastole, when the heart is fully relaxed. Before it starts contraction, some valves will be open, the mitral valve will be closed, and the aortic valve is about to open. You don't have to complicate yourself with those names. But anyway, the ADV we have seen is too high. And the amount that remain in the heart after contraction, the ESV, end systolic volume, is much. And the amount ejected out of the heart is less. So basically, this patient heart is like this. Can you imagine? Now imagine this is the heart here. The patient heart is not contracting. So when we look at the echo, there was one video that has not been played. When we look at the echo, we look at how much contraction the heart can do. Normally, the heart is supposed to contract to 50% of its volume. So I'm going like this, and I go like this, almost 50%. You see, this is how I'm bumping, almost to 50%. I know this motion of the heart is okay, but the motion was not okay in this patient. Second thing, the heart, instead of contracting almost to 50% of its size, is just shaking, is making like this. So the contraction is very superficial, it's not very, so that's why a lot of blood still remains in the heart after contraction. So we have, we have a systolic dysfunction in this systolic mean contraction. We have contraction problem. The heart is failing to contract. The heart is too relaxed and is failing to contract. I have another patient, but I don't know if I have the videos ready. I have another patient that is totally the opposite, where the heart is failing to relax. So these are the two main conditions that we look at when we evaluate the heart. Is the heart failing to relax, or is the heart failing to contract? That is the two main categories. Each category has a different, yes. See, this one?
The heart with a scanner to look. Number one, based on experience, let me use this pointer here. You see, this is the right ventricle. It is bigger than usual. And that is exactly what the ECG has told us, that there is right axis deviation with left axis deviation. Meaning both chambers, as we see in this machine here, both of them are dilated. Both of them are dilated. So I can see also that, I want you to notice the contraction of the left ventricle. It's supposed to contract to almost 50% of its size. It is not. It is just shaking, but is not contracting well. So contractility in this patient is compromised. If I look at this valve here, this is what we call the mitral valve, and this is the left atrium right here. The left atrium is also enlarged, okay? The left atrium is also enlarged. So we have a problem. We have a dilated cardiomyopathy that so far include enlarged left atrium, enlarged left ventricle, enlarged right ventricle, and the right atrium, we will not be able to see it from this view here. But here we can see the mitral valve. You know, it's supposed to reach the wall, but it's hardly reaching. Now, if we do a cross section.
Okay, perfect. So this is also, so we have seen with this patient, we have seen life. We can see inside the heart, and we can see that the left side of the heart is enlarged because of too much volume. We can see the right side of the heart is enlarged because of too much volume. So this patient definitely will have difficulty in breathing because the right side of the heart is connected to the lungs. And when we have overflow, when we have volume overload like this, when we have too much overload because of the blood is not moving as it's supposed to, we will have difficulty in breathing in this patient, because now what we have, we will have what is called pulmonary hypertension. So this patient is a young patient, and it is sad that he is already suffering this kind of condition. This condition we see in all patients, it happened to be in a young patient. So we have right ventricular hypertrophy and his volume overload. We have left ventricular hypertrophy and his volume overload also. The conclusion is, and we've seen the left atrium, and also the right atrium is not shown in this view, but if we can see all the chambers, all 4 chambers of the heart are dilated, this is what we call 4-chamber dilated cardiomyopathy, meaning all 4 chambers of the heart are full of blood and they are overloaded with blood because the heart cannot move the blood out. It gets the blood in, but it cannot move it out. So when we have stasis, when the blood stays like this and is not moving, the movement is eliminated or the movement is minimized, then this patient must take a blood thinner. Must take a blood thinner. Please